Hello everyone. Hope you all are having a great day. Today we are going to learn about the topic nephrotic syndrome, which is also known as proteinuric kidney disease or nephrosis. So we'll start with the definition. Nephrotic syndrome is a glomerular disorder characterized by first, massive proteinuria of greater than 3.5 gram per day in adults. This is hallmark of nephrotic syndrome. Second, hypoalbuminemia of less than 3 gram per deciliter. Third, edema, generalized including periorbital and pedal edema. Fourth, hyperlipidemia, greater LDL VLDL due to liver compensation. Fifth, lipiduria, oval fat bodies, Maltese cross under polarized light. Now we move on to the etiology. Primary, idiopathic, nephrotic syndrome. This is minimal chain disease, most common in children, 80%. Focal segmental glomerulosclerosis, FSGS. It is most common in adults, 40%. Membranous nephropathy, common in adults, associated with PLA2R antibodies. Secondary nephrotic syndrome, diabetic nephropathy. It is the most common secondary cause. Lupus nephritis, amyloidosis, and infections are some of the other causes. Drugs, NSAIDs, gold, penicillin, and malignancies such as solid tumors in the lung, colon, breast, Hodgkin's lymphoma. These were some of the causes. So we finished with the etiology. Now we move to the pathophysiology. So first, the podocytes get damaged. Glomerular basement membrane loses its negative charge. Proteins, especially albumin, leak into the urine. This leads to massive proteinuria of greater than 3.5 gram per day. Second point of pathophysiology is hypoalbuminemia, means decreased albumin in the blood. Due to excessive albumin loss in urine, blood albumin levels will drop. Less albumin leads to decreased oncotic pressure. Fluid leaks into the tissues, therefore causing edema. Third point is liver overcompensation. Now how liver overcompensation? The liver tries to compensate for low albumin by producing more proteins, including lipoproteins, LDL, VLDL, cholesterol. This leads to hyperlipidemia and lipiduria, fatty casts, oval fat bodies in urine. Clinical features. Symptoms. First is edema, periorbital puffiness, swelling in legs, ankles. Second, frothy urine due to proteinuria. Third, fatigue and weakness due to hypoalbuminemia. Fourth, shortness of breath if there is pleural effusion or severe edema. Fifth point, oliguria, decreased urine output due to fluid retention. Sixth, abdominal discomfort due to ascites. Now we move on to the signs. There is pitting edema, common in legs, sacrum, periorbital region. There is lipiduria, fatty casts and oval bodies in urine on microscopy. There is hypertension due to hypovolemia, RAS activation. Tachycardia. Fifth, ascites and pleural effusion. Sixth, signs of thrombosis, swollen painful leg in DVT and flank pain, renal vein thrombosis. Now we move on to the investigations. So urine investigations. First, gold standard is 24-hour urine protein collection. This confirms proteinuria of greater than 3.5 gram per day, which is diagnostic of nephrotic syndrome. This is most important point in investigations. Spot urine protein to creatinine ratio, UPCR. UPCR of greater than 3 to 3.5 mg per mg suggests nephrotic range proteinuria. Urine analysis. Oval fat bodies, Maltese cross pattern, fatty casts and high link casts may be observed. Blood investigations. Serum albumin of less than 3.5 gram per deciliter due to protein loss in urine. Serum cholesterol, increased LDL, total cholesterol of greater than 300 mg per deciliter and greater triglycerides. Renal function tests. Serum creatinine and urea to assess the kidney function. Fourth point is serum electrolytes may show hyponatremia. Then we do the imaging. Imaging USG kidney, normal in minimal chain disease, increased echogenicity in chronic renal disease. Doppler ultrasound if renal vein thrombosis is suspected. CT or MRI renal venogram if renal vein thrombosis needs confirmation. Some immunological tests like complement levels C3 and C4. Now complications. Complications first is thrombosis, renal vein thrombosis, DVT. Second, infections, spontaneous bacteria peritonitis, pneumonia sepsis. Third, CKD, progression if untreated. Now we move on to the management. Goals of management. First, control proteinuria and preserve kidney function. Second, reduce edema and complications. Third, identify and treat underlying cause. Now general measures. Salt restriction. This is very important. Of less than 2 gram per day. This controls edema. Second, reduce protein intake. 0.8 gram per kg per day. Avoids excessive kidney overload. Third, diuretics, furosemide, spironolactone, and avoid if there is severe edema. Lipid control. Statins if needed, only if there is severe dyslipidemia. And fifth is thrombosis prevention. If albumin is less than 2 gram per deciliter, consider anticoagulation, heparin, warfarin. Thank you and keep supporting us.